And warm welcome to everyone to iFocus Online Lecture 524, the 15th in Eyes in Systemic Diseases. Today we have Dr. Richa Pyare from Shroff's Eye Center, New Delhi, to speak to us on ocular toxicity from systemic drugs. She completed her MBBS from Lady Hardinge Medical College, New Delhi, her MS Ophthalmology from Guru Nanak Eye Center, Maulana Azad Medical College. She's the fellow of the International Council of Ophthalmology, did her medical retina and uvea fellowship from Shankar Nethralaya, Chennai, also did a short-term fellowship in pediatric retinal diseases and lasers in diabetic retinopathy from Arvind Eye Hospital, Madurai. She's currently the consultant at Shroff's Eye Center, New Delhi. She has received several prestigious awards like the Professor Narsingh A. Rao Award for the Best Free Paper, the UCCON 2024, AIOS Rima Mohan Award in AIOC 2016. She's published multiple papers in peer-reviewed journals of reputed journals with 150 plus citations. She's a reviewer for the Ocular Immunology and Inflammation, European Journal of Ophthalmology, and Delhi Journal of Ophthalmology. She's the invited speaker at several national and international conferences. She's an active member of the UOC Presidential Working Group, with UVA as her focus group in the year 24 to 25, and she's organized several webinars, weekly case discussions, and journal clubs. Her keen area of interest is medical retina and uvea, and she's extremely passionate about teaching programs for both fellows and postgraduate. We're very glad to have you here, ma'am. Over to you.
Thank you, Mahima, for that very kind introduction. I'll just share my screen. Yeah. Is my screen visible?
Yes, ma'am.
All right. So the slides are moving?
Yes, ma'am.
Okay, so starting off, ocular toxicity from systemic drugs. Good evening, everyone. Thank you, Santosh Unawar sir, and thank you, Partho sir, for inviting me to this, and thank you to all the postgraduates who have logged in. I am Dr. Richa Pyare, and I'll be talking about ocular toxicity from systemic drugs. So how is this presentation organized? So I will be organizing this presentation ocular structure wise, because that makes the most logical sense to me. And within each structure, we will try to cover the most important drug in some detail, and then we will mention in passing others that also cause drug toxicity, but are not as commonly used or are not as important. With each drug, I've tried to organize the material into the same subheading so that it's easier for you to remember and you can have like recallable points for your exam as well. So let's jump right in. First, the cornea. The two most important drugs that you need to remember for corneal toxicity are amiodarone and antimalarials. Now, amiodarone, you can see in the first column the subheadings that basically give you an overview of the things that you need to remember about this drug toxicity: the class of the drug, the proportion of patients that are affected, the time taken to presentation, whether they are dose dependent or not, whether it is a reversible toxicity or not, are there any visual defects from the toxicity, and whether drug discontinuation is required. So for amiodarone, it is a anti-arrhythmic drug. Almost all patients on amiodarone will show some form of vortex keratopathy, which is the corneal toxicity associated with it, very soon after starting the drug. It is a dose-dependent reaction toxicity, which means it adds up over time, it builds up over time. However, the drug deposition only causes mild blurring. It is reversible on stopping the drug, and drug discontinuation is not really warranted for vortex keratopathy. So what is the timeline like? The timeline is basically when the amiodarone is started, it starts off with fine golden brown opacities, which forms a irregular horizontal line, and then slowly it forms this classical irregular branching pattern, which then swirls out or whirls out, causing this vortex-like configuration. It is usually below the pupil, it spares the limbus. All right. Okay, yes. So management, like already said, it is usually not required. These drugs this toxicity is reversible on stopping the drug. What are the other drugs that can cause a similar vortex keratopathy? Chloroquine and hydroxychloroquine, which are a class of antimalarials and DMARDs, also can cause vortex keratopathies. They take weeks to months to manifest. They are not dose dependent, they are reversible, and again, drug discontinuation is not warranted. Other drugs, vandatanib, which is a targeted cancer cell therapy. We'll be hearing more about these later in the presentation. can also cause a vortex keratopathy. Tamoxifen, which is a breast cancer drug, again, will feature again later in the presentation, also causes this. NSAIDs like ibuprofen, indomethacin, naproxen can also cause vortex keratopathies. This is a list which shows an overview of all the various drugs that can deposit in the various corneal layers. Not much to talk about here, but if you see deposits in the cornea, taking an extensive drug history is mandatory. Okay. After cornea, moving on to the ciliary body. Now, ciliary body means ciliary body effusions, and the most notable drug is, of course, topiramate. Now, topiramate is a very important drug. It is a anticonvulsant. It is commonly prescribed for migraine. It is a sulfa derivative. The time to presentation is usually within a month, usually within 2 weeks, in fact. It is not a dose-dependent reaction. It is an idiosyncratic drug reaction, which you can figure out. It's a sulfa derivative, so it's going to cause all of these allergies that sulfa derivatives are famous for. It is reversible on stopping the drug. Visual effects can range from mild to very severe. There can be redness, pain, and drug discontinuation is required. Now, this usually presents as ciliocoroidal effusions. This is because of increased permeability of the choroidal vasculature, which can lead to choroidal detachments. It can lead to exudative retinal detachments, and topiramate-induced acute angle closure, which basically happens because the effusions cause the lens iris diaphragm to shift forward. There is a myopic shift, again, because of this forward shifting of the lens iris diaphragm. Uveitis can also be caused, and this is because of a different mechanism. This is because of the drug metabolites binding with intraocular proteins, forming a complex which the immune system reacts against. All right, so some pictures to just explain what we've talked about. This picture shows, I don't know if you can see my cursor. Can you guys see my cursor moving on the screen?
Yes, ma'am.
Yes, ma'am.
Great. So this, you can see this blackened space. This is the effusion of the in the choroidal and ciliary body, and this is pushing this iris, and this is the anterior surface of the lens forward and causing this angle to become really narrow, this AC to become really shallow. And post-treatment, stopping the drug, you can see that the iris and the lens have moved back. The angle is again open. The AC is deep again. This is a picture of choroidal effusion causing choroidal detachments. And this is a patient with bilateral hypopyon anterior uveitis. This is post-treatment. The anterior uveitis has resolved, but there is a complicated cataract. Okay, so what is the management? Like already mentioned, stopping topiramate is an important first step. IOP lowering agents like AGMs need to be started. Pilocarpine needs to be avoided because it can precipitate a pupillary block. Laser PI is not useful because there is no pupillary block. Cycloplegia is important. Steroids, either topical or systemic, depending, of course, on the intensity of the inflammation. Okay, so what are the other drugs that can cause ciliary effusion? Other sulfa derivatives can also cause a similar reaction. So antibiotics like sulfamethoxazole, diuretics like acetazolamide, or insulin secretagogues like glipizide can cause a similar ciliary effusion. They also present within a month. These are also idiosyncratic drug reactions. They are not dose dependent. They are reversible on stopping the drugs, and the visual effects can lie on a spectrum from mild to severe. Drug discontinuation is important in all of these reactions. Others like oseltamivir, which was Tamiflu, which is an antiviral. Anticoagulants can mimic effusions because they can cause suprachoroidal hemorrhages and cause the same displacement of the lens iris diaphragm. All right. So cornea, ciliary body, and now uvea, which means drug-related uveitis. The most notable drugs, classically, we talk about cidofovir, we talk about rifabutin, and we also talk about bisphosphonates, which cause drug-related uveitis. Another class of drugs, which is really important now, are the immune checkpoint inhibitors. We'll talk a little bit more about them later. Okay, so cidofovir. What was cidofovir? It is a antiviral. It was used for CMV retinitis. Typically in immunocompromised patients, typically in HIV positive patients, it was given both intravenously and intravitreally, intravenously once in 1 to 2 weeks, or intravitreally every 5 to 6 weeks. The proportion of patients affected was huge. Almost 90% of patients who got cidofovir were affected by cidofovir-related uveitis. The time to presentation, usually it builds up over time again. So this is a dose-dependent reaction. So with repeated infusions, the risk of uveitis was more. It was partially reversible on treatment with steroids, cycloplegics, but a lot of case reports and case series note recurrences of the anterior uveitis on stopping the steroids and persistent hypotony also. Visual effects again depends on the inflammation of severity of inflammation, and drug discontinuation was usually required. Now I keep saying was because cidofovir is not used as frequently now because of these side effects. It presented as acute anterior uveitis with hyperpian, with fibrinous exudates, with vitritis, which could resemble endophthalmitis. Ocular hypotony was very characteristic. And the hypotony was more intense with intravitreal injections. It could also cause exudative retinal detachments, choroidal detachments, and macular folds because of the hypotony. Now, management against steroids, cycloplegics, and dose reduction or discontinuation. The next most easily rememberable drug-causing drug-associated uveitis is rifabutin. What is rifabutin? It is most commonly used for prophylaxis or treatment of Mycobacterium avium complex or atypical mycobacteria, again in immunocompromised patients, again typically HIV patients. Most of what we know about the rifabutin-related uveitis is from case reports in the mid-1990s when it was given along with clarithromycin, which is again a component of the anti-MAC regimen, and with ritonavir, which is part of ART or antiretroviral therapy. Now, both clarithromycin and ritonavir and fluconazole actually cause an increased risk of rifabutin-related uveitis because it inhibits the hepatic cytochrome P450, which would then inhibit the metabolism of rifabutin, causing accumulation. So, like already discussed, these are antimycobacterial drugs. 2 to 3 months after starting is usually when we would see this uveitis. It is a dose-dependent reaction. It was unusual at the recommended dose of 300 milligrams per day. And they were reversible. The visual effects were diminution of vision with pain and photophobia. Drug discontinuation or reduction of dose was almost always required. Now, the important thing to remember is they caused hyperpian anterior uveitis, right? Which was bilateral, but there was minimal or no congestion, which was very unusual. So you had a patient with pain, photophobia, hyperpian anterior uveitis, but it was hardly any congestion. Again, vitritis, which may be mistaken for endophthalmitis, sometimes retinal vasculitis or panuveitis can also happen. Management, steroids, cycloplegics, discontinuation, pretty standard. Moving on, bisphosphonates. Now, bisphosphonates are, of course, used for osteoporosis management. Specifically, palmidronate is the bisphosphonate most commonly associated with drug-induced uveitis. There was a theory initially that only amino group containing or nitrogen containing bisphosphonates would lead to uveitic reactions, but now there are case reports showing almost every type of bisphosphonate leading to uveitis. So what is the time to presentation? Because these start happening very fast. So 1 to 6 days after IV infusion, palmidronate is usually given as an IV infusion. The proportion of patients affected, now 30% of all those affected would have an anterior uveitis, less than 15% would have scleritis or episcleritis. If you had a pre-existing inflammatory syndrome, you were more likely to present with bisphosphonate-related uveitis. It was a dose-dependent reaction. It is a dose-dependent reaction. It is reversible. Visual effects, again, depends on the intensity of the inflammation. Drug discontinuation is usually required. Most commonly, a self-limiting conjunctivitis, and the second most common presentation would be an anterior uveitis. Management, yes, depends on the severity and type of inflammation. Like already mentioned, conjunctivitis is typically self-limiting, but it requires the drug to be discontinued. Discontinuation of offending drug is important because re-challenge usually led to recurrence of the uveitis. You can try switching the bisphosphonate, but you have to switch out of class. Example, give denosumab, which is a monoclonal antibody, again used for osteoporosis management. Steroids, topical steroids for milder cases, but there were even cases of posterior scleritis that were described, and orbital inflammation. So in those cases, you would need systemic, which is IV corticosteroids. IV AMP would be required. And they were usually required to reduce the inflammation because it would be a very painful condition, and they were required to prevent further complications. Again, cycloplegics depending on the intensity and the main structure that is affected. Now, immune checkpoint inhibitors. I want to take a little bit time here. This next class of drugs are an extremely important cause of drug-related uveitis. But before I get into the specifics about the uveitis caused by immune checkpoint inhibitors, as this is a very new class of drugs, I'm going to take some, assume that a lot of you aren't really familiar about what these are. And so we'll take a short segue and try and understand what immune checkpoint inhibitors are. So within the cancer chemotherapy world, there is a new group of drugs called targeted chemotherapy drugs. Now, targeted cells drugs, as the name suggests, oh, I don't know what happened. Okay, sorry. So targeted cancer therapy, as the name suggests, theoretically are supposed to be more focused on the cancer and as opposed to the conventional chemotherapy, which kills all rapidly dividing cells. These targeted therapies are further divided into, oh, wait. I think there's something happened with my presentation. I can't, one slide is missing. Anyway, so, like I was saying, these within these targeted cancer therapies, there are two main classes of drugs: immune-related therapies and non-immune therapies. Among the immune therapies, the important ones that we need to know about are immune checkpoint inhibitors. So our immune system is actually a very important line of defense against cancer cells, but there can be an immune escape where these cancer cells learn to evade the immune system. They kind of put a brake on the immune system action against them, and they start proliferating without any checks. So immune checkpoint inhibitors sort of cut the brake on the immune system cells, specifically the T cells, and now the reactivated immune system can act on and destroy cancer cells. Another class of drugs, non-immune related, are small molecules, and within them, the important group of drugs that we need to keep in mind are the MAP kinase inhibitors, or mitogen activated protein kinase pathway inhibitors. So two important types among them are MEK inhibitors and BRAF inhibitors. So moving on to immune checkpoint inhibitors, by inhibiting, like I said, the immune system responses of signal, the ICIs activate the body's immune system to attack cancerous growths. And so, as expected, adverse effects will be due to an excess of immune system activation or inflammation. And these are also called immune-related adverse effects. It's an entire class of adverse effects. Now, in fact, there have been studies that show the higher responsiveness of the cancer to these ICIs, the higher the risk of these immune-related adverse effects. All right. So what are ICIs? They are targeted cancer therapies. Time to presentation is usually within 3 to 6 months. It is a dose-dependent reaction. It is reversible on treatment. Visual effects varies, depends on the severity and type of uveitis. They are bilateral. Drug discontinuation may be required in very severe cases. Example, VKH-like uveitis. Most commonly, they present as dry eye. Up to 25% of patients on these ICIs will have dry eye. Up to 6% will have uveitis. The uveitis is most commonly an anterior uveitis, followed by a pan-uveitis, especially a VKH-like response. Posterior uveitis and intermediate uveitis follow. They also lead to an increased incidence of paraneoplastic associated retinopathy. What does that mean? These are few paraneoplastic syndromes that would happen due to the primary tumor. Now, these have become more there's been an increased incidence because after using the ICIs. Okay, just a few images. Now, this is one of my patients who was on an immune checkpoint inhibitor, and he came in with he had a stage 4 renal cancer. He walked in with bilateral pan-uveitis with a dense, complicated cataract, and the pupil was basically plastered onto the anterior lens capsule. And this is the clinical picture in the first visit. As you can see, there's a very hazy view of the fundus. This was the OCT scan where there was cystoid macular edema and some subretinal fluid in both eyes. I started him on topical steroids I talked to the onco team. They were not willing to change the immune therapy because this was basically their last resort for him. So on topical steroids, he actually started improving the inflammation calmed down. Once the inflammation was controlled with topical steroids, I gave him an Ozurdex first in the right and then the left, and we planned the cataract surgeries after 2 weeks of the steroid of the Ozurdex injections. And this is his OCTs in the final visit. So when he came and his vision was counting fingers 1 to 2 meters bilaterally, he was not ambulatory, and he responded really well to the steroid therapy and walked out 6/9 and 6 both eyes. So very gratifying response to steroids in these cases. Management, actually, there are specific treatment guidelines. There is a CTCAE criteria which grades the uveitis and gives us treatment recommendations. Long story short, management depends on the severity of the inflammation. Very severe inflammation may warrant stopping or switching of the ICIs. That's about it. All right. So moving on to the second class of drugs that we were talking about, the MEK and BRAF inhibitors. Now, MEK and BRAF inhibitors are actually given as a combination very frequently. They inhibit different steps of the RAS-RAF-BRAF pathway, which basically means that this combination will have a certain set of toxicities, and individually as monotherapies, MEK and BRAF inhibitors have a different set, a similar but sometimes distinct set of drug toxicities. So MEK-BRAF inhibitor combination therapy is typically associated with a VKH-like response. Now, these basically, if you can see these clinical pictures, it causes a ciliocoroidal effusion again. The choroidal effusion can lead to a choroidal detachment. If you see these OCT pictures, they look very typically like that of VKH. There are RP undulations, there's subretinal fluid, there is a ballard. The FFA shows these pinpoint leaks, which then fill up the neurosensory detachments. Now, what are MEK-BRAF inhibitors? Again, they are small molecules targeted cancer therapies. Time to presentation, again, is probably 3 to 6 months, but these are very rare for us to have like a very definite idea of how, when should we expect uveitis to come. They are dose dependent. Yes, the VKH response is more frequently seen with the combination therapy. They are reversible. The visual effects, as you can expect from a VKH-like response, will be a very severe diminution of vision. They are reversible, but they usually need a dose reduction or discontinuation. So the case reports in literature say a total drug discontinuation followed later by restarting the drugs at lower doses. Systemic steroids, IVMP, is often required. Local depot injections like Ozurdex may also be required. What are the other drugs causing uveitis? Sulfonamides, TNF-alpha inhibitors, vaccines very commonly. BCG can cause a bilateral acute non-granulomatous or granulomatous anterior uveitis. MMR can cause anterior or pan-uveitis. Influenza vaccine can lead to a pan-uveitis or an APM-PPE. Hepatitis B vaccine is also associated with uveitis. Anti-VEGF agents, we all know about brolucizumab. Anti-glaucoma, I know this is not a systemic drug, but I want to highlight that brimonidine causes a granulomatous anterior uveitis with a raised IOP, and that is associated with chronic use of brimonidine. We all know about PG analogs already, but brimonidine is also an important cause of uveitis. So moving on to the next structure, the lens. Obviously, this is something that we all know. Steroids will cause cataracts. Steroids, both topical and systemic, will cause cataracts, which present as a posterior subcapsular or an anterior subcapsular and mature cataract. Steroid given over months or years usually lead to cataracts. It is a dose-dependent reaction. It is not reversible. Steroids can usually be continued till the cataract till the primary pathology is resolved, and then the cataract surgery can be done. Other drugs which can cause cataracts include chlorpromazine, allopurinol, and gold. Another major section which is retina, the important drugs that cause toxicity in the retina include chloroquine or hydroxychloroquine, pentosan polysulfate sodium, MEK BRAF inhibitors again, and tamoxifen. Now, when it comes to retina, we divide drug toxicity into different buckets depending on the level or at which they affect the retina or the mechanism by which they affect the retina. The first mechanism is disruption of the retina and retinal pigment epithelium, leading to a pigmentary retinopathy. And the most important drug is hydroxychloroquine. Now, hydroxychloroquine is a anti-malarial and a DMARD. Time to presentation presents years after starting the drug. The proportion of patients affected depends again on the cumulative dose. About 7.5% of patients who've had hydroxychloroquine for more than 5 years can present with this maculopathy. Pardon. And 20 to 50% of patients with more than 20 years of hydroxychloroquine can present with this maculopathy. Like already mentioned, it is a dose-dependent reaction. The risk increases with cumulative doses over 1,000 grams, which basically works out to 200 milligrams BD for about 7 years. It's rare if the doses are less than 5 milligrams per kg real weight per day. Now, what does real weight mean? Real weight means lean body weight, excluding the weight due to fat, because hydroxychloroquine does not deposit in fat. Increased risk with renal impairment and with tamoxifen use. It is usually not reversible, especially in more advanced cases. It continues even after the drug has been discontinued. Visual effects, it can lead to permanent loss of central vision. Drug discontinuation usually has to be discussed with the rheumatologist because it's noted to have survival benefits, especially in SLE patients. It presents as a progressive maculopathy. So there are stages of the maculopathy that we need to talk about. So there is a pre-maculopathy. There is early functional and structural changes. It is prior to even visible fundus signs. The goal of screening is to detect it at this stage where it is still reversible. Now, this basically shows a normal OCT and normal visual field, probably like a baseline. And this would be the pre-maculopathy stage where you can see over here, there is a focal loss of the ellipsoid zone, which is most commonly seen in the infratemporal quadrant first. MFERG can also pick up findings at this stage, and visual field can find some early centrocecal scotomas or some changes. Now, early maculopathy, where the vision reduces to 6/9, 6/12, there is a loss of foveal light reflex, there's subtle macular stippling. OCT shows a flying saucer sign, which means that there is parafoveal loss of the outer retina. The ellipsoid and ellipsoid zone and the other outer retinal layers are discontinuous parafoveally, leaving a ring in the center. If you see this looks like a flying saucer. So this is called the flying saucer sign. Fundus autofluorescence will show areas of affected RPE, areas which are just starting to be affected are hyper autofluorescent, and areas which have been affected chronically are hypo autofluorescent. Finally, we have the bullseye maculopathy stage where the vision reduces to 636, 660. There is a foveolar island of pigment surrounded by a depigmented zone of RP atrophy, again circled by a hyperpigmented ring. There is RP atrophy, there is arterial attenuation. There can even be pigment clumps looking like bony spicules. The OCT shows a loss of RP and the ellipsoid zone. FAF shows the typical bullseye pattern of alternating hyper and hypo AF. Now, hydroxychloroquine screening is very important. The AAO has come out with a guideline recommendations on screening for patients starting hydroxychloroquine. They all have to have a baseline screening before starting the hydroxychloroquine, or within the first year of use. There's a fundus examination, and usually visual field or SD-OCT, which is spectral domain OCT, needs to be done if there is any evidence of maculopathy. Annual screening needs to start 5 years after if the patient has been on hydroxychloroquine. And it can be done sooner in presence of major risk factors, like we already discussed. Renal impairment and tamoxifen use are some of them. Now, what are the screening tests that are recommended? Most importantly, SD-OCT and visual fields. Now, visual fields, which visual fields should we get? Non-Asians, especially Caucasians, a 10-2 was typically recommended, but we know that Asians have a more peripheral disease. So for Asians, which is like which includes Indians, it needs to be a 24-2 or a 30-2. Other tests, if available, include an MFERG and fundus autofluorescence. The fundus autofluorescence is very useful, gives a very nice visual picture of where the RP is like, what is the health of the RP. Okay, other tests which may be important in future include microperimetry, fundus examination, time domain OCT, fluorescein angiography, a full field ARG, Amsler grid, color testing. None of these are recommended for screening. Okay. Now, moving on from hydroxychloroquine to pentosan polysulfate sodium. This is not a drug that we really typically hear about a lot, but this is actually the only FDA-approved drug for bladder pain syndrome or interstitial cystitis. And this was seen in patients. This specific drug toxicity, this maculopathy, was seen in patients who've been on PPS or pentosan polysulfate sodium for many years, for more than 15 years. It is a dose-dependent reaction. It is risk is more if the cumulative dose exceeds 1,500 grams. It is reversible, but it is, I mean, again, like as with hydroxychloroquine, once it becomes advanced, it continues despite stopping the drugs. Visual effects again include diminution of vision, and patients often say they have difficulty in reading because of paracentral scotomas and metamorphopsia. There is a prolonged dark adaptation, which is very important, and drug discontinuation is required. So it presents as a pigmentary retinopathy. There is a parafoveal pigmented deposit at the level of the RP. There are vitelliform, which means yellow colored deposits. There is patchy paracentral RP atrophy, which mimics a pattern dystrophy. And late complications can include macular edema, complete atrophy of RP centrally, and a CNVM. Now, these images basically will help us understand what I was talking about. So these pigment spicules, can you see them in the posterior pole? This is the pigmentary changes that we see on the color photograph. And fundus autofluorescence is important. Fundus autofluorescence shows this speckled hyper AF in the posterior pole, which means that these are like these dot-like hyper AF, hyper autofluorescent white stippling that can be seen, and it has a peripapillary extension. What does a peripapillary extension mean? It means that there is no gap between this stippling and the disc. It is contiguous. And why is this important? It's important because pattern dystrophy, which it can mimic clinically, typically has a peripapillary sparing. So this kind of corridor is going to not have this speckled hyper autofluorescent appearance. These hyper AF spots correspond to vitelliform fundus lesions or correspond to the yellow dots, these yellow dots on the fundus. OCT can show focal nodular RP excrescences. What does that mean? It means that the RP is like a little bit bulky like this. Okay, can you see? And focal atrophic spots can be seen later on. Okay. So what are the other drugs that can cause a similar pigmentary retinopathy? Phenothiazines, which are antipsychotics, chlorpromazine and thioridazine. Digitalis or digoxin, which is a second-line treatment for atrial fibrillation and symptomatic heart failure. Okay. Moving on to, or going back to MEK inhibitors, monotherapy now. So MEK inhibitors, like I said, are usually used along with BRAF inhibitors. A combination therapy has a more severe drug toxicity, but MEK inhibitor monotherapy classically is associated with something called MEK inhibitor associated retinopathy, or MECAR. So again, revising what we know about MEK inhibitors. These are targeted cancer therapies. The time to presentation is 14 days for this MECAR specifically. We're not sure if they're dose dependent because they happen overwhelmingly in up to 90% of patients. They are self-limited, so yes, reversible. Visual effects are mild to moderate blurring of vision, and drug discontinuation is usually not required. Again, self-limited. What is MECAR? MECAR is a CSR-like reaction that happens in patients on MEK inhibitors. This is what this MECAR looks like. These are bilateral, symmetrical, multifocal, frequently involve the fovea, like you can see in this photo over here, red photo over here. Unlike CSR, there is no inferior guttering. CSR fluid, once if it stays long enough, if you remember, they will form these dark RP tracts on autofluorescence called guttering. These resemble mercury beads held tight by capillary action. They don't leak on FFA, again, to differentiate them from CSR. There are no PEDs on OCT, no choroidal hyperreflective dots, no choroidal thickening, again, versus CSR. Okay, so what are the other drugs that can cause CSR or CSR-like reactions? So of course, we have steroids, which cause CSR. They will leak on FA. And we have something called FGFR inhibitors. These are again part of the same small molecule anti-cancer therapy drugs. They act upstream of MEK kinase and cause CSR-like lesions similar to MECAR. MDMA, which is a recreational drug, and sildenafil. Vascular damage. Now, we have discussed drugs that cause disruption of the retina and the retinal pigment epithelium in the retina. And now we are going to talk about drugs that damage the retinal vasculature. Again, MEK inhibitors, monotherapy can cause a CRVO-like reaction. Now, CRVO in MEK inhibitor therapy is a very severe reaction. They're very rare, so we don't know how long they take to present. We don't know how much, whether they're dose dependent or not. It has a variable prognosis. Anti-VEGFs are usually required. A lot of case reports say that it means that MEK inhibitors have to be stopped permanently. Getting a CRVO is a severe reaction. This is a picture from a case report on CRVO secondary to MEK inhibitor monotherapy. Now you can see that the entire retina has this, splash tomato appearance or blood and thunder appearance, whatever you may want to call it. And there is severe macular edema, but post anti-VEGF, the macular edema did settle down in these patients. What are the other drugs causing a similar vascular damage? Most important, talc retinopathy. Now, talc retinopathy, we will again talk about when we talk about crystalline retinopathies. Now, talc, how does talc get into the retina? So IV drug abusers will crush oral medications. These oral medications contain talc as an inert filler, basically something to like hold the drug particles together. And once they crush these oral medications, they will inject it intravenously. These talc particles will then find their way through the blood circulation and end up stuck in the very fine end arterioles of the retina. So this picture again, if you can see these glistening yellow dots, these are all talc particles which have ended up in the end arteriole. See over here. Okay, ischemic retinopathy may develop in case enough arterioles are occluded. So capillary non-perfusion areas, microaneurysms, cotton wool spots, neovascularization, all of this can happen. Some other drugs which can cause this vascular damage include intraocular antibiotics like vancomycin, which causes an HORV, which is hemorrhagic retinal vasculopathy, and aminoglycosides, most commonly gentamicin, followed by tobramycin and amikacin. Interferons, which are again anti-cancer drugs, can cause vascular damage, lead to cotton wool spots and retinal hemorrhages, and areas of capillary non-perfusion on FFA. After drugs that disrupt the retina and RPE, we've talked about vascular damage, and now we're talking about cystoid macular edema. Drugs that cause cystoid macular edema, very importantly, anti-diabetic drugs, glitazones, rosiglitazone and pioglitazone can cause CME. In diabetic patients not responding to anti-VEGF, if you feel that they have diabetic macular edema and it's not responding, check the drug list. They may be on one of the glitazones. Fingolimod, which is again an immunomodulatory therapy used in multiple sclerosis. Imatinib, trastuzumab. These are what we call leaking CMEs on FFA. Non-leaking CME on FFA is caused by nicotinic acid, which is a cholesterol-lowering agent, and it's caused by anti-microtubule agents, which are again anti-cancer drugs, Taxol and docetaxel, but these are part of conventional anti-cancer drugs. Just a pointer that PG analogs, even though conventional wisdom is that PG analogs cause both uveitis and CME, it has now been proven by a meta-analysis that PG analogs don't cause cystoid macular edema. Okay, crystalline retinopathy. Most important drug to cause crystalline retinopathy is tamoxifen. If you remember, we talked about tamoxifen depositing in the cornea, causing a vortex keratopathy, and it can also cause a crystalline retinopathy. It is an anti-estrogen medication used for breast cancer. Time to presentation, again, depends on the dose. High doses present early, within a year. Low doses after 2 to 3 years. It is rare at standard doses. It is reversible. The visual function and macular edema, yes, it is reversible. Crystalline deposits can persist. Visual effects is blurring of vision. Drug discontinuation is usually recommended. Now, again, crystalline retinopathy means bilateral fine yellow crystalline deposits in the inner layers of the retina. Punctate gray lesions in the outer retina, matlab you have these pigmentary changes, there can be macular edema. Their OCT can show hyperreflective lesions in the inner retina, cystoid macular edema, and foveal cysts similar to what we see in early stages of MACTEL. Other drugs, talc, again, remember vascular damage and crystalline retinopathy. Ritonavir, again, the ART drug, canthaxanthine, methoxyfluorine, nitrofurantoin, fludarabine, they can all cause crystalline retinopathies. Okay, out of the retina into the optic nerve, ganglion cells and optic nerve. The most important drug we all know, ethambutol, also amiodarone, and another new class of drugs called GLP-1 receptor agonists, vigabatrin. Okay, ethambutol first. Ethambutol is anti-tubercular drug. The time to presentation for ethambutol toxicity is between 3 to 6 months. It is a dose-dependent reaction. At standard daily doses of 15 milligram per kg per day, the proportion of patients affected is 1 to 2%, which is very less. And once the daily dose goes above 35 milligram per kg per body weight, the proportion of patients affected shoots up to almost 20%. It is variably or partially reversible. In 30 to 64% patients, there is some recovery. Early diagnosis and cessation of ethambutol is very important. Maximal recovery can take up to 1 year. Visual effects, in basically, how does the patient present? The patient will present with bilateral, insidious, painless blurring of vision with color vision defects if the patient is can notice these things very keenly. Drug discontinuation is required, and some people have suggested ionish discontinuation as well, because isoniazid can also cause a toxic neuropathy, which potentiates the ethambutol toxic neuropathy. So the toxic optic neuropathy, there is the reduction in the visual acuity. How does the optic disc look? Because it's a retrobulbar optic neuropathy, there can be none to very mild optic disc edema with few splinter hemorrhages, may or may not have RAPD initially. There is a red-green dyschromatopsia, and some have suggested that loss of contrast sensitivity could be an early sign of ethambutol toxicity. How do you diagnose? Visual fields, VEP, OCT. So visual fields will show a central or a centrocecal scotoma. VEP will show that the optic nerve is not working. There's a prolonged latency and reduced amplitudes. GCC, thinning on OCT initially, along with a mild RNFL thickening, which then progresses to RNFL thinning, which again is also suggestive of progressive damage. And there is relative symmetry in both eyes. Why is ethambutol toxicity suddenly more important? It's always been important, but it is now more important because in 2022, the Ministry of Health and Family Welfare came out with new guidelines for ATT in patients with drug-sensitive TB. Drug-sensitive TB basically means the first-line TB. First-line TB used to be 2 months of HRZE and 4 months of HR. H is isoniazid, R is rifampicin, Z is pyrazimide, and E is ethambutol. Now, the ATT standard regimen for all patients with drug-sensitive TB or all first-line patients is 2 months of HRZE and 4 months of HRE. So we're giving 6 months of ethambutol. And if you recall, so more the dose of ethambutol cumulatively given, higher the risk of toxic optic neuropathy. So yes, we have been seeing an uptick in patients with ethambutol-related optic neuropathy. There has been an effort to figure out screening guidelines. How should we screen for patients who have to go on ethambutol? So the Indian Neuro-Ophthalmology Society came out with these guidelines that there should be a baseline visit at an ophthalmologist before starting these drugs. And the baseline visit should have a visual acuity. It should have color vision, contrast sensitivity, visual field, baseline OCT RNFL, and a VEP if possible. There should be 2 monthly follow-up visits, and patients should be encouraged to do self-assessment of visual acuity, self-assessment of color vision, and visual fields on smartphone-based apps or on Amsler grids. Okay. Now, another new class of drugs. One of the newest class of drugs that probably all of you have heard about is glucagon-like peptide 1 receptor agonists. If you've not heard this name, you would have heard Ozempic. Semaglutide or Ozempic has basically taken both medicine and social media by storm. And now in India, we already had the oral form of semaglutide, which is Rybelsus, but now Mounjaro, which is an injectable tirzepatide, has also been introduced. These drugs are basically kind of revolutionizing how we manage diabetes and obesity. There has been, I mean, the amount of patients who've been put on these GLP-1RA was so high that the company ran out of Ozempic. Like the company that made Ozempic ran out of Ozempic. All of this is just to give you context on why it is important that you know about these drugs. Novo Nordisk, the company that makes Ozempic, has an annual turnover more than the GDP of the country where it's headquartered now. We are going to see more and more patients being put on these drugs. We are going to see more and more patients coming up with ocular adverse effects because of these drugs. So what are they? They are used in type 2 diabetes, in obesity, in cardiovascular disease. There is a possible role in chronic kidney disease, in metabolic dysfunction associated steatohepatitis or MASH. In OSA, which is obstructive sleep apnea, in Parkinson's. And what do they cause? So they have been implicated in NAION. And when do they present with NAION? Within a year. Are they dose dependent? This we are not sure yet. Is the NAION reversible? No. There is another presentation of this drug toxicity, which is worsening of diabetic retinopathy. The worsening diabetic retinopathy is probably reversible. Does it mandate drug discontinuation? We're not sure yet. So NAION may be unique to semaglutide, may not be important with tirzepatide, but we don't have enough data yet. What are the issues? Basically, why don't we understand what is happening with this NAION in GLP-1RA? It's that NAION itself is a very rare disease. There is lack of a clear biological mechanism by which this GLP-1RA is causing NAION. Some possible theories are that it may alter the glucose metabolism, making the optic nerve more vulnerable to rapid glucose fluctuations. Another thing that people are proposing is that the rapid glucose control, rapid weight loss leads to disruption of pre-existing vascular stability, potentially increasing the risk of NAION. What does this mean? It means that the weight loss and the glucose control is so rapid, it's so fast that it can precipitate fluid shifts in your body, like systemic fluid shifts, reduces the plasma volume, it alters the ocular perfusion. Now, these changes will compromise the blood flow to the optic nerve, particularly in patients who have an impaired vascular autoregulation. Now, basically, it means that it acts so fast that even though reduction in blood pressure and vascular resistance is good, the vasogenic autoregulation in these patients with these chronic metabolic syndromes is so bad that this rapid reduction itself will cause a compromise in ocular blood flow. It can also cause a worsening DR. This again is supposed to be likely due to the rapid glucose control, or this even in classical DCCT and UKPDS, all of these classical old, uh, uh, you know, sorry, all of these old studies have also shown that a rapid glucose control will cause a sudden worsening, initial worsening of the diabetic retinopathy, but over long, over the long term, this improved glucose control will lead to a better overall control of the diabetic retinopathy. So this is a transient reaction. There are even there's even a paper that now seems to link increased neovascular AMD in patients in diabetics who are GLP RA1 exposed versus non-exposed. So very, very dynamic kind of field right now. Other drugs causing optic nerve damage. So amiodarone, probably secondary to some type of demyelination. Vortex keratopathy and optic nerve damage, the two things that happen with amiodarone. It is not a dose-dependent reaction though. That one was, vortex keratopathy was. This, whether is it reversible, that is variable. Discontinuing the drug usually improves vision, but 20% may deteriorate further. 1/3 are asymptomatic, the rest have blurry vision. Drug discontinuation in this case is required. So not required for vortex keratopathy, but for optic nerve damage, it is required. Vigabatrin can cause bilateral, concentric, predominantly nasal visual field constriction. Sometimes isoniazid is also associated with optic nerve damage, and tetracyclines, vitamin A, retinoids can cause idiopathic intracranial hypertension. So what is the take-home message? There is a wide range of systemic drug-induced ocular toxicities, and the landscape is very dynamic, especially with the rapid introduction of new drug classes in both oncology, immunology, and a complete drug history in any new onset, unusual, or recalcitrant ocular disease is very important. Keep the possibility of drug-induced adverse effects and work your way through the drug list by eliminating possibilities. Continuing medical education, webinars, conferences are very important to keep track of new drug classes and potential adverse effects. Once new drugs are launched, a pattern of new ocular drug adverse effects will emerge, and it will invariably find its way into talks and conferences like this one. So try and stay current. Thank you.
Thank you, ma'am. Thank you for that very comprehensive coverage of this vast topic. I'm sure it was challenging to do it in this limited time. We have some questions, ma'am, if it's okay with you.
Yeah, please.
Yeah. Yeah. Ma'am, one of the first things that we learned when we started residency during cataract surgeries was to take history of tamsulosin use. So the intraoperative floppy iris from tamsulosin, is it dose related or duration dependent, and can it still occur after stopping the drug?
So it can still happen after stopping the drug. Whether it is dose related or not, I am not certain. This tamsulosin, however, like if the patient has been started on tamsulosin, usually the prostate enlargement is not going to suddenly stop. So once you stop the tamsulosin, the prostate starts increasing again. So it's very tough to stop the drug anyway. So you have to learn how to deal with it. So stopping the drug is not really an option.
All right. So it's not usually recommended to stop it before the surgery, is it?
No, not stopping it before the surgery will not really help.
Okay, fine. All right. Okay. Ma'am, are there any surgical challenges while operating a TENS PSC due to steroid use as opposed to an organic PSC, which has happened by itself, not because of drug insult?
Not really. Not really. I think they behave, surgically they behave about the same. There's no difference. In case the steroids were given for any kind of uveitic conditions, so that itself can cause, if the patient has had uveitis, there can be associated iris, posterior synechiae and other issues. But just a pure PSC itself is going to behave just in the same way as a non-steroid related PSC. Yeah.
Right. Ma'am, are there any alternatives considered in patients who require HCQ but show early signs of retinal toxicity?
That's actually a great question. So rheumatologists will have to be, I mean, you have to consult with the rheumatologist who is, giving the drug. You have to see the indication for giving the HCQS. Like I said, in conditions like SLE, it seems to give a survival benefit. Now, if there is a survival benefit and the patient is responding, the rheumatologists are usually very reluctant to stop the HCQS. On the other hand, there are other conditions like sarcoidosis for which it is given, and there it can usually be easily replaced by something like Foley tracks. So depends on the condition, depends on the clinical context, and it has to be like a give and take with the rheumatologist.
Okay. So this has to be a decision made together
Yes,
with the
with the
consulting
rheumatologist.
rheumat.
And of course, you
Okay.
have to understand that if there's a maculopathy, the patient has been stable on that drug for 5, 6, 7, 8, 9 years probably. The second important thing to consider is that even if you stop the drug earlier, if you stop the drug earlier, yes, there is a better chance that it will reverse, but it can still continue. So even the AAO guidelines don't really say that drug needs to be stopped. They basically say that yes, the maculopathy is going to be there. Do you need to discontinue the drug? Probably not, because whether or not you stop the drug, it can still progress.
All right. Ma'am, it must be different for different drugs, but is there like a blanket duration for how long it takes for reversal of symptoms and signs after stopping drugs for
Not really.
any toxicity?
No, depends. Again, so if you're talking about things like, again, it also depends on the level of the ocular structures you're talking about. If you're talking about, say, vortex keratopathy, so they start reversing as soon as you stop the drug. So it starts fast, it stops fast. If you're talking about, like, again, we talked about ethambutol toxicity. Ethambutol toxicity, they appear within 3 to 6 months, but they can take up to a year for whatever reversal needs to happen for that. You can wait for up to a year for the patient to improve. So it's really very different. And again, it also depends on the amount of dosage or the cumulative dose that the patient has received.
Okay.
So all of those factors will determine that. Okay.
All right. So it is very much dependent on the drug and it cannot
Yeah.
be put into one bracket.
Yeah. Yes.
Okay,
Yeah.
fine. All right, ma'am. Thank you so much for that great session. I am sure it's going to help a lot of postgraduates and also other practitioners.
Thank
Am
you so
I
much.
audible?
Yeah. Thank you so much for having me.
Am I audible? I think I'm
Yeah,
cut
yeah.
out.
Yeah, we can, I mean, I can hear you.
Okay, fine. Okay, for all our other viewers, the next session is going to be on the 30th of July, which would be the last session in this module on multimodal imaging in systemic diseases by Dr. Aniruddha Agarwal. That would be the last session for this module, and you can all await further details for the next module, which would be on optics and refraction in the next month of August. And before we all sign out, one little announcement. Is my screen visible?
Yeah.
For all our other viewers, this is the penultimate call for iFocus, the physical iFocus 2025, which is being held in New Delhi this year from August 10 to 17, which is the National Postgraduate Education Program in Ophthalmology. We have the last 30 seats remaining, 2 weeks to go for the program. This is sort of your last chance to go grab them before they're all gone. You do not want to miss this. You want to be there to witness everything that is happening in ophthalmology in all the different specialties by all the other stalwarts. So see you all there and see you again for the next session. Thank you so much, ma'am.